All right, class. So we're going to go over a couple. Hi, class. We're going to go over a couple topics that we didn't get to touch on Tuesday. So the first one we're going to do is going to be vertebral artery. So assessment of the vertebral artery. So vertebral artery, so it's included in our carotid artery exams. Artery. But it's really a limited assessment that we do. So it's limited assessment. For flow direction. That's the big one. We're assessing flow direction. So flow direction, is it antegrade? Versus retrograde? You know, antegrade is also cephalid. Retrograde would be caudal. So in addition to flow direction, we're also assessing patency. Is it occluded or is it not occluded? And RI, resistive indice. So is it high resistance? Is it low resistance? So for a real assessment of the vertebral basilar system, we'll get a better assessment of these vessels using an arteriogram. Or an MRA. Using magnetic resonance imaging. Or a CTA. With a CAT scan. So arteriogram, MRA, or CTA are better suited for full evaluation of vertebrobasilar system. System. So vertebral vascular disease. So we have something called VBI. This is vertebral basilar insufficiency. Vertebral basilar insufficiency. So what is that? That is, as the name implies, insufficient blood flow supplied by the vertebral and basilar arteries. Insufficient blood flow supplied vertebral basilar arteries. So these patients will have posterior circulatory symptoms. So going over those symptoms again, things like syncope, where you faint and black out and lose consciousness, drop attacks, where you fall but still maintain consciousness, vertigo, that's when you get the sensation like things are spinning, the room is spinning, loss of balance, loss of coordination, bilateral symptoms. So, bilateral paresis, bilateral vision, just visual disturbances like diplopia or double vision. So this can lead to transient vertebro-basilar ischemia or even vertebro-basilar stroke. So VBI can lead to transient meaning temporary, transient vertebro-basilar ischemia. Or vertebro-basilar stroke. Again, these symptoms are typically multiple and varied and can be difficult to evaluate as well. Some causes. The eyes. So the main cause is going to be atherosclerosis. Atherosclerosis is the building up of that plaque. Not to be confused with arteriosclerosis. So for arteriosclerosis, that's the hardening of the arteries. I remember art is hard. I'm not a good artist, so that's the way I remember. Arteriosclerosis is the hardening of the arteries. Atherosclerosis is the buildup of the plaque. So the common site for atherosclerotic stenosis. Common site for atherosclerotic stenosis is at the origin of vertebral artery. And also intracranial just beyond the C1 vertebrae and the vertebral arch. Also intracranial beyond C1, the cervical spine, first level. In the vertebral arch. And vertebral arch. Some other causes could potentially be embolization. So that could be a clot that's traveled into the vertebral artery and is now blocking the blood flow, causing that insufficiency or lack of blood flow. Another potential cause could be vertebrobasilar ectasia. Vertebral basilar ectasia. We could potentially also have cardiac arrhythmias or dysrhythmia. I apologize. Dysrhythmia. Steele syndrome. And vertebral artery impingement. So some anatomic considerations for the vertebral artery. So the two vertebral arteries join at base skull to form common basilar artery. So basilar artery is the only artery that's formed by the junction or coming together of two arteries. So another anatomic consideration, there's a wide range of collateralization, collateral, what else? Collateralizations. With multiple arterial anastomoses or connections present in the circle of Willis. Multiple arterial anastomoses present in the circle of Willis. Another anatomical consideration. The vertebral arteries are asymmetric in size. With the left, we'll underline that, left vertebral is larger in 80% of people, 80% of population. Symmetric in size. Left is larger in 80% of people. Origins are tortuous. Tortuous origins. This is particularly true in elderly. Elderly. And the origins are deep to the clavicle, especially on the left side. Let's put deep through clavicle. Especially left earth. And again, assessment is limited. It's limited to bony structures. So as we know, it runs through those transverse processes in the spine. So we get that shadowing of the vessel as it's running through the spine, through the bone. So we can't, image or assess those segments of the vessel. As well as the distal / intracranial segments. once it goes into the brain, obviously we cannot image it anymore. So diagnosing disease in the vertebral arteries is difficult. That's why it's typically recommended that, the hospitals do a different study like an arteriogram, an MRA, or a CTA. So the vertebral artery is broken up into several segments. So for us imaging, V1 and V2 are really the segments that we're going to be imaging or could potentially be imaging. So V1 is from the origin to the C6 level of the spine. So the sixth cervical spine. This is origin to C6 level spine. And this is the segment which does not run within processes of spine. So those transverse processes of spine. The easier segment to image or to visualize is going to be that V2 segment. So this is a segment of the vessel that runs from C6 to C2 for our spine levels. And this is where we see vessel running through processes of spine. So those are those images that we get, where we get the shadow, we get the spine, the transverse process of the spine, vessel running through. We lose it as it goes through that spine, and then it reappears, and we're Dopplering and imaging between those segments of spine, between the cervical levels of the spine. So the V3 segment of the vertebral artery, this is from C2 to the dura. C2 to the dura. That's where it enters the brain. Or the skull, I apologize. Or it enters the skull. And V4 is the intradura. So into the skull or inside the skull to the origin of the basilar artery. Intradura. to basilar artery. Before is intradura. Once you get into the skull to its end or the origin of the basilar artery, where it connects to the basilar artery. So there are numerous muscular branches, the anastomose with occipital branches of the ECA. With numerous muscular branches, which anastomose or connect with occipital branch of ECA. I'll take any chalk donations. I've almost killed a box this week. All right, so normal vertebral ultrasound features. So normal features that we will see on ultrasound. So first thing is going to be cephalad flow towards the brain, cephalad. These are going to be normal features. More resistant flow. You know that. Velocity. Between 20 and 60 centimeters per second. Diameter is variable. As we've seen here in our lab, if we've been scanning each other, some of us have nice, big, beautiful, huge vertebrals. And other people's are teeny tiny little things that are difficult to image. So again, I'm going to highlight that again, star They're asymmetric. Size. With left larger. And velocity is usually higher in dominant vertebral artery. So again, being able to determine flow direction is probably the most important aspect of us scanning the vertebral artery. Just a quick refresher on flow direction. So we got our ultrasound screen, got my color box. All right, so I'm steering my color box in that direction. So we know this is the top of the screen. The top of the screen is going to be the source of our ultrasound sound waves. So ultrasound sound waves are being propagated down. If you think about it that way. So all the ultrasound, when we have our linear probe, the beams are headed straight down. So that's our direction of our sound beam. Our fancy transducers these days, we're actually able to steer that beam now using sequencing of the firing of the crystals to allow us to angle. So when we put our color box on, we're actually now, instead of the beam coming straight down perpendicular, we angle our sound waves in the direction of that box. So if my box is steered in that direction, my sound beams are now traveling in this direction. And they're going to be parallel to the angle of my box. So now in order for us to, really understand and determine flow direction, we have to be able to understand the direction that the beam is going. And then also understand, our direction of our blood flow with regards to whether the blood is coming towards those ultrasound beams or if it's going away from those ultrasound beams. If I have a vessel, just say for instance, coming up that way, makes a turn, goes that way. It goes down like that. So we'll do red towards, we'll do blue as away. So if we're in long, we're imaging our carotid arteries. This side of the screen, the left side of the screen is going to be our notch. So our notch is pointing up. So this side of the screen is always going to be your notch, regardless of what you're imaging, what you're doing. Your notch is going to be the left side of your screen. So if we're doing carotids, this is going to be our head. That's the notch pointing up towards the head. And be your feet. So if we're imaging a normal carotid artery, blood flow is going to the head. So it's headed up in that direction. The blood flow in this instance, in this segment of the vessel, is heading towards our sound beam. So that portion of the vessel is going to appear as red. We'll get into a segment of the vessel where the blood flow is actually perpendicular or 90 degrees to our angle of our ultrasound beam. And based on our Doppler shift equation, we get cosine theta. So when your angle is 90 degrees, cosine theta becomes 0. So when you put 0 into your Doppler calculation, the multiplication winds up with 0. So the ultrasound machine will spit that back out as a 0, that there's no blood flow, there's no Doppler shift. So there'll actually be an area that is perpendicular to the ultrasound beam where you will not get any color filling. So there'll be a small segment of the vessel with no color that's perpendicular to that blood flow, where the blood flow is perpendicular to the angle of the beam. And as the blood rounds the corner, this segment of the vessel now, the blood flow is now tailing away from that ultrasound beam. So it's running away from that beam. So from that curve to this segment, this is going to now be blue. I could take that same vessel. I could steer my color box the other direction. And it's still not going to change. So now ultrasound beams are going in this direction. This segment of the vessel is still away, still going to be blue. This segment of the vessel is coming towards our ultrasound beams. They're going in this direction, but we're still coming towards it. So in our color box, this segment's going to be red. We'll still get that area where we have 90 degrees of inclination, which appear black or absence of flow. So a general rule of thumb in terms of like angling and steering the box, I like to look at which bottom corner the vessel is running towards. So if I have a vessel that's kind of coming across like this, and it's taking like a little bit of an angle down like that, I'm going to want to put my color box steering towards the bottom corner where this vessel is going. So vessel is going in this direction towards that bottom corner. I'm going to have my color box. I'm going to want to steer it towards that bottom corner. The more you steer your box, the more of an angle, like when we're sampling also, our sample gate goes along that. So we got our sample gate. We have like our little angle line, which we want, perpendicular. Typically we want to maintain 60 degrees. A lot of labs like to keep that angle, have you keep it at 60 degrees and keep it consistent. Because changes in that angle will affect velocity. So if I can't get a good angle on that, I'll try steering my box a little bit more. And that might help me to be able to adjust, that caliper to ensure that I'm perpendicular. My sample gate is perpendicular to the flow. And I do that by aligning it to the vessel wall, making sure it's parallel to the vessel wall. So again, if I have a vessel that's coming up this way, blood flow is still going in this direction, but my vessel's tailing down that way. Essentially want to put my color box angled that direction. So if it's going straight across the screen, switch both ways, try both directions, see what feels better, Don't get fixated on just one angle and one steer. Don't be afraid to change your angle. Like I said, if the vessel's not filling, it could be three things. It could be your angle, it could be your scale. You may have to adjust your velocity scale. Because remember, the machine, based on the settings, will have built-in wall filters to filter out low velocities or filter out high velocities, depending on what your preset functions are. So it could be your angle, it could be your scale, or it could be your color gain. Raise or lower the gain of your color. All right, so like we said, vertebral arteries. So we know it's low resistant flow. Some other characteristics, velocities are fastest at the origin. And greater than 90% of VA, vertebral artery stenosis, occurs at origin. So there you can see another additional problem or issue with imaging the vertebral, because we typically don't see the origin, or it's difficult to visualize the origin just because of its anatomical location. So that's why these other modalities are usually better at assessing the vertebral basilar circulation in its entirety. So if we think about that, if most of our stenoses are at the origin and we don't see the origin, what could potentially be a waveform that we would then see? So if we go back to our waveform lectures, a post-stenotic waveform is going to be our tardus parvus waveform. Tardus parvus. A post-stenotic waveform would be our tardus parvus, which is our pyramids, a little pyramid. So tardus means slow, parvus. Tardus late, parvus slow. So it's our late acceleration and low amplitude. So I didn't give any diastolic flow. Sorry. Give a little diastolic flow. There we go. That could be a potential waveform that we see. So some abnormal vertebral ultrasound findings. Abnormal findings. Potentially you could have absent flow. Normal flow direction. With abnormal flow direction, anything that deviates from solid flow is abnormal. So that's anything from complete reversal to bidirectional flow. So that's going to be our vertebral to subclavian steal syndrome. This is our vertebral subclavian steal syndrome. Some other abnormal findings. We have small size, small diameter. So they could be atrophic. We may find elevated velocities. So a tartarus parvis waveform is caused by a high-grade stenosis, so a severe stenosis, or even potentially an occlusion. We may have a stenotic lesion, which is significant, but not significant enough to create a tartarus parvis waveform. So that could potentially give us elevated velocities, so a proximal lesion. Something else that can potentially give us some elevated velocities. Say for instance, the patient has an occlusion of the right internal carotid artery, the right vertebral artery, the ipsilateral, the same side vertebral artery would typically demonstrate increased velocities in order to feed the brain through the circle of Willis, through the posterior communicating artery. So that's when we open up those collateral channels. So as a compensatory mechanism to ipsilateral ICA occlusion. Or think about another scenario would be contralateral vertebral occlusion. Contralateral vertebral occlusion. Again, this is going to be a compensatory mechanism. So we have an obstruction or a blockage in one of our vessels going up to the brain. The brain's going, oh, hey, I need oxygen. What's going on? I got a blockage here. So what the body's going to do, it's going to have the blood vessel dilate. It's going to expand. Velocities are going to increase. That vessel expands, becomes larger in diameter. So we get more flow able to travel through those vessels. It's less pressure on the vessels. So we have a greater pressure gradient. So less pressure in the vessels because they're dilated. We have a decrease in the pressure within the vessel. So that increases the gradient. So we have the higher pressure of the heart, lower pressure in the vessels going up to the brain. So blood flows from high to low. So we're getting increased velocities, increased forward flow, dilated vessels, all in the name of trying to get blood flow to that brain. around those stenotic lesions. So that's a couple of reasons why we would see increased velocities. We could potentially see decreased velocities. So decreased velocities. So some things that would give us decreased velocities. Potentially be post stenotic parvus. Reduced cardiac output. Another abnormal finding potentially would be a vertebral artery dissection. Artery dissection. So a little bit more about flow reversal with our subclavian steel. I had mentioned, a steel could be complete or partial. You talked a little bit about that bunny rabbit sign. So with flow reversal, it's going to be more common on the left side, more common left vertebral. And with flow reversal on the right side, we must remember to determine if it's in the innominate versus the subclavian. On right, must determine stenosis is and innominate versus subclavian. So again, how do we do that? We look at the right common carotid artery and check to see if that has retrograde or antegrade flow. So if the right common carotid has cephalic flow, if it's antegrade, then we know that that blockage is not in the innominate artery. It's going to be in the subclavian. But if we get retrograde flow in both, we know it's a very proximal occlusion because it's now affecting both arteries. So that stenosis is going to be in the innominate artery before the level of the right common carotid, before that bifurcation. Some secondary diagnostic findings in patients with subclavian steel. So we may have abnormal velocity waveforms in the distal subclavian artery. I'm going to put this under secondary findings of subclavian steel. The abnormal Doppler velocity in distal subclavian artery. So if it's a suspected Steele syndrome, if we were to Doppler the subclavian artery distally out towards that shoulder, we should get very diminished velocities or very unusual waveforms. They're not going to look like your typical arterial waveforms. So it'll be diminished velocities because blood flow isn't getting to the arms from the heart through the arteries. It's being siphoned away from the brain through the vertebral and potentially the right common carotid. The normal Doppler velocities, they're going to be low. Low amplitude waveforms. Another secondary finding for subclavian steel, it's going to be our brachial pressures. So we'll have a systolic brachial pressure difference of greater than 15 to 20 millimeters of mercury between the normal and the affected arm. So difference systolic EP greater than 15 to 20 millimeters of mercury, Hg. So difference in systolic BP greater than 15 to 20 millimeters of mercury. And brachial arteries. So the side with the steel is going to have the lower pressure. You just kind of think about that logically. You know, you got something blocking the blood flow getting to that arm. So the arm isn't receiving the same kind of pressure, the same kind of blood flow. So obviously the pressures are going to be lower in the affected arm. So pressure lower in affected side. That's usually the first red flag with patients in the hospital. When nurses on the floor, they take a blood pressure on one side and they go, oh, wow, it's really low. And they go and check the other side and like, oh, the other side's not bad. You know, and then they realize they have this difference in pressures. And then they wind up sending them to us to do a carotid study or an arterial study. And we try and diagnose subclavian steal syndrome. So again, go on to the PowerPoints and study some of the PowerPoints, look at some of the waveform pictures, you know, familiarize yourself with the waveform pictures, and you know, learn to recognize some of the different types of steel, that it doesn't necessarily have to be completely retrograde, that you can have bidirectional flow and a partial steel. You can have an abnormal waveform where you may not even necessarily have significant velocity below the baseline, depending on the severity of the steel. So look for that bunny sign. So like we said, the vertebral arteries are asymmetric in size, and size is variable. So large side-to-side differences may occur in normal individuals. So it's normal sometimes for patients to have one side that is significantly larger than the others. The non-dominant vertebral artery is an anatomically small vertebral artery, and it may demonstrate increased resistance, so higher resistive indices, as well as diminished flow velocities. Say small size. So a small vertebral artery, we could say a hypoplastic atretic vertebral artery. Is one that measures less than 2 millimeters. Right. Hypoplastic atretic vertebral artery measures less than 2 millimeters. Small vessels will have higher resistance and lower velocities. Oh, man. That's a dirty board. All right, so vertebral artery stenosis. So with the carotid arteries, the internal carotid artery, let me preface that, the internal carotid arteries, we have a criteria for determining or defining the severity of stenosis. So with vertebral arteries, there is no criteria for determining severity of stenosis based on velocities So if we remember our chart for ICA velocities, just go over that real quick. So ICA stenosis. This is a chart that you're going to have to memorize, get in your brain. So 0 to 50% stenosis, peak systolic velocity. Make sure you guys can see this. There you go. So 0 to 50% stenosis, peak systolic velocity. It's going to be less than 125 centimeters per second. (69% stenosis). It's going to be 125 to 230 centimeters per second. There's 70 to 99% stenosis. It's going to be greater than 230 centimeters per second. That's just quick. Go back in your chart because there is an end diastolic velocity component as well. That helps you to determine severity of stenosis, particularly if you have tortuous vessels. That end diastolic velocity component comes into play. So look that up. So with severe stenosis greater than 70 to 99% stenosis, you'll have end diastolic velocities at greater than 100. I want to say 100. As well as you will also have another grading criteria called your carotid ratio. So with your carotid ratio, this is taking your proximal ICA velocity over your distal CCA velocity, your peak systolic velocity, and you get an equation. So with severe stenosis, your velocity, your carotid ratio is greater than 4. But go back to your chart and your PowerPoints, try and commit those all to memory. Anyway, I digress. So getting back to vertebral artery. So there's no real criteria for determining severity of stenosis based on velocities. You can get a velocity ratio. So velocity ratio greater than 2 is equal to a greater than 50% diameter reduction. So what that means is if we're Dopplering our vessel in 2 different segments, I'm just going to write down velocity ratio greater than 2 equals greater than 50% diameter reduction. So that's another point when we're talking about cerebrovascular circulation. We don't classify a stenosis or a blockage as what's called hemodynamically significant until it gets over that 50% threshold. So a hemodynamically significant stenosis is greater than 50%. So when you get in the lab and you start writing up your reports for carotid Doppler exams, that's going to be your line. That's your go-to line. No evidence of hemodynamically significant ICA stenosis visualized bilaterally. If it's a normal study or if there's minimal plaque that's less than 50%, that's going to be your go-to final line for your preliminary report. You then would potentially go into describing the plaque that you do see, like heterogeneous plaque seen within the right carotid bulb, and you give a plaque estimate of about, say potentially 30%, 20%, you give your best estimate. But your go-to line at your under report is going to be that no evidence of hemodynamically significant ICA stenosis. And you will potentially, describe plaque in other segments if you see plaque in the CCA, ECA. But at the end of the day, what they really care about is stenosis within the ICA. So anyway, again, I digressed. I apologize. I'm just kind of thinking of things along the way. Anyway, so with this velocity ratio, when we get back to vertebral arteries, so velocity ratio greater than 2, what that means is if we're imaging the vertebral artery and we see something that we may consider a stenotic lesion or a blockage, we see elevated velocities or potentially aliasing in a segment, that looks turbulent, and we Doppler and we see an increase between two segments of greater than 2. So if we go from 50 to 100 centimeters per second, or we'll say 50 to 110, so greater than 2, that would equate to a diameter reduction at that stenosis of greater than 50%. That's really the only grading criteria that we have. We can't really tell if it's 50, 60, 70, 80, 90, that's hard for us to do. So there is another condition called Bow-Hunter syndrome. Bow-Hunter's that Bow-Hunter's syndrome. So with Bow-Hunter syndrome, this is a rotational occlusion of the vertebral artery. So this is done with a head turn, with the rotation of the neck. By doing that rotation, the patient winds up with an occlusion of the vertebral artery due to a rotation of the head. And it's associated with changes in head and neck position. So Bow-Hunter syndrome, that is a occlusion of vertebral artery due to rotation and positioning of head. Positioning of head. So decreased velocity, we mentioned, could be due to a proximal occlusion. So that would be our TARDIS Pivers waveform. You can also throw back there on your notes that it could potentially also be due to a distal obstruction higher up that gives us, say, that thumping waveform. So maybe we have an occlusion somewhere higher up, more distally, above where we're sampling, and we see a high resistant waveform and reduced velocities. So decreased velocities. Good. Also be due to a distal occlusion. So that distal occlusion Low with high resistance waveform. Well, this all goes back to being able to read your waveforms. What's it telling you? You know, when I worked with Dr. Pellerito, that was his big thing, was training us to read the waveforms. You know, what information are you getting from this? What could potentially it be? And having you really understand your waveforms, because the answers are there. So distal occlusion, depending on how far away you are from that occlusion, if you're close or proximal to that occlusion, that's when you'll wind up with just your thump, the little blips. This is proximal to occlusion. So proximal, I mean close, not that, well, yes, we are still proximal to the occlusion. No, God, I'm like, so yes, I mean, I'm gonna rewrite that. Close to a distal occlusion. Or in close proximity to a distal occlusion, we'll get that thumping, just those little blips. If the distal occlusion, that upstream blockage, is further away, we may just have just high resistant waveform. With little to no diastolic flow. Those would be further from a distal occlusion. I hope you guys don't mind. I'm kind of just like backtracking, going back over a little bit, some of the stuff that we went up before, just kind of trying to reiterate points, you know. So proximal obstruction will have our dampened tardius parvus waveform. Distal obstruction would be a high resistant waveform. All right, so we'll talk a little bit about MRA and CTA. So ultrasound, you know, it's useful because it's cost effective, it's cheap compared to an MRI or a CT. You know, there's no radiation, so it's, I mean, it's a good first initial choice, you know, to get an initial overall assessment for the vertebral arteries. But if we need a more, you know, in-depth look, If we're suspecting, potential blockage that's potentially intracranial where we can't see, or at the origins that we can't see, or say, we image a Steele syndrome and we can't exactly find that stenotic lesion in the innominate artery because it's too close to the heart and we can't visualize it. The doctors may be forced to order, a different imaging modality. So one option for them, like we said, would be an MRA using magnetic resonant imaging. So MRAs, they're minimally invasive but they do have limitations. So some limitations are not all patients can get an MRI because you're using a magnet, using the MRI machine. That limits our patient population a little bit. People who have had intracardiac devices, pacemakers, leads, anything metallic in them. These patients aren't candidates for getting MRIs. So anything that would limit a patient from being able to receive an MRI, they're unable to get this procedure. And then also there's a signal dropout in regions of severe flow turbulence, or also in regions of very slow flow. So another limitation, you get areas of signal dropout. Areas of signal dropout where turbulence or slow flow are present. So the other option would be our CTA using a CAT scan. So computer tomographic angiography. And this provides high resolution images of the posterior circulation in patients with contraindications. In patients without contraindications to iodinated contrast material or impaired renal function. So with the CTA, we get high resolution images. But can not be used with patients who are either allergic or have contraindications to contrast. Not be used with patients who are allergic or have contraindications to contrast. So that's the patients with renal failure. All right, so real quickly, we'll go over treatment. Golly. I'm left with these little nubbins of chalk. All right, so treatment. So patients with posterior circulation ischemia, they often also present with a mixture of both carotid and vertebral artery disease, and they often have a higher mortality rate. So what that's saying is that usually posterior circulation disease isn't an isolated thing. So these patients typically also have carotid artery disease on top of vertebral artery disease. So, and those patients, if they have disease in both, often have a higher mortality rate. So, say posterior circulatory disease is usually seen in conjunction with carotid artery disease. So this is under treatment. So direct vertebral artery reconstruction using surgical procedure of vertebral artery transposition or bypass have outcomes comparable to an endarterectomy. So vertebral arteries, we can't do the endarterectomies that we do with the carotid artery. So in these cases, they'll do either a vertebral artery reconstruction using a vertebral artery transposition, or they will do a bypass, a vertebral artery bypass. So direct vertebral artery, reconstruction using bypass. Or third artery transposition. As outcomes similar to endarterectomy. So just a refresher, endarterectomy, that's when we surgically remove the atherosclerotic plaque from the internal carotid artery and bulb. And we also remove typically a portion of the lumen as well. So we do an incision, open up the bulb for their endarterectomy, surgically remove the plaque and a portion of the lumen to open up that vessel again and get blood flow into the internal carotid artery. So that's your carotid endarterectomy. Another treatment could be angioplasty and stenting. But these typically have higher restenosis rates, earlier restenosis rates. So we can also stent and angioplasty. So angioplasty or balloon angioplasty is when we go into the vessel and we inflate a balloon to open up the vessel and create a wider channel. And we then typically place the stent in there to keep it open. So stent and angioplasty. They have good initial success, but have high rate of restenosis within 2 years. Alrighty, so that is vertebral arteries. Stay tuned for your next exciting chapter in vascular ultrasound. I'm just gonna take a little break, clean myself off, and we'll get into some topic of atherosclerotic plaque and the different kinds of plaque. So I'll be posting that video shortly. Thank you.